Hi friends, it's April 30th, the end of a very long month for me, and I'm sure for many of you as well. Thanks for spending part of it with me. It's been really nice having some folks to talk to. I went into the office today to deal with a couple of pounds of paperwork. I really should have waited before and after just to see exactly how many sheets of paper I just signed. Forms are one of those non-urgent things that wait in the setting of a pandemic. But now all of a sudden their urgency has returned, and all of my patients who are like, I'm going to die if this form doesn't get filled out today, have come out of the woodwork, which I'm very happy to see, that so many of my patients are well enough to come out of the woodwork. What they were doing in the woodwork, I'll never know. I haven't had the time or courage really yet to open up the part of my inbox where I see all of the hospital admissions and all of the discharges, because I'm sure that at least a few of those discharges are going to be to death, and rather than to home or to a facility. So I'm not looking forward to figuring out who we have lost from this, but neither here nor there. I don't want to get too morbid, because what I want to do is talk about Remdesevir a little bit. Big story. Mostly yesterday, Wednesday, the news really picked up on it because the NIH released top-line data from their randomized controlled trial of Remdesivir. I'll talk about that in just a second. There's actually 3 trials that came out relatively close together. The first was a compassionate use study in the New England Journal where they just gave 64 patients Remdesivir in a fairly unscientific way, just compassionate use. As I said, the FDA approved it for compassionate use in patients with coronavirus, and the rate at which patients' oxygen requirement declined was nominally higher than expected. So it was written up as like, hey, maybe it's good. Then there's the trial in the Lancet, which I'll come back to, and then there's the NIH trial, which on the surface looks very good. It's a randomized placebo-controlled trial of a little over 1,000 patients, 1,080-ish, I think, receiving either Remdesivir or placebo. The inclusion criteria are likely published on clinicaltrials.gov, but were not published in the press release itself. And the top-line data is very impressive in as much as the time to recovery was something on the order of magnitude of 30% lower in patients getting study drug compared to placebo, which is great. Time to recovery seems like a surrogate outcome, but it's actually very frequently used for things like influenza drugs, just because if your outcome is mortality, your power calculation gets pretty icky pretty quickly, just because not so many people die in one hospitalization from this. If you're looking at something like coronary artery disease, you can follow thousands and tens of thousands of patient years relatively easily, because patients accrue events roughly evenly over this period, whereas for Remdesivir, you can only follow the hospitalization. And so unless your mortality rate is extraordinarily high, which thank goodness ours has not been extraordinarily high, secondary outcomes like time to improvement actually matter. And there's every reason to think that if you improve faster on the drug, it is working. It has an antiviral effect. And so I think that's fine. And there was a numerical decrease in overall mortality, something like, I'm going to say 8 versus 11%, with a p-value of 0.059. And not to get too into p-values, traditionally we use 0.05 or less as our threshold for statistical significance, which is of course arbitrary. For those not in the know, the p-value represents, and some of my colleagues are going to kill me if I get this wrong, the p-value represents the probability that the null hypothesis is correct. In most research trials, the null hypothesis is there is no difference, and all differences are observed by accident. And so if your p-value is less than 0.05 or 5%, then there is a less than 5% chance that the differences you're observing are accidental, and thus a 95 or better % chance that they are really truly because of the differences between the groups that you're the variable that you have created and controlled. So 0.059 is not significant, but at the same time, it's less than 6% chance that these are arbitrarily different. Coincidentally different. Different not because of Remdesivir. It's pretty good. 6% chance is pretty good. Now, meanwhile, we have this trial in The Lancet, which is also a randomized placebo-controlled trial out of China, in which far fewer patients, 200 and change, were randomized 2-to-1 to remdesivir versus placebo. I don't know if it was actually intentionally 2-to-1, but that's how the groups roughly shook out, so I assume that was done intentionally. And that's a negative trial. Trend towards faster recovery, but no significant difference. So when you have a positive trial and a negative trial of the same drug, you of course have to ask yourself why. And there's a couple of apparent results. Number one, I just told you that the NIH trial was about 5 times the size of the negative trial in The Lancet. So you could just imagine it's a power difference, that had the Lancet trial been 5 times the size, it too would have showed a significant difference in at least recovery time, if not mortality. Number two, you can imagine that there is a fundamental difference in the patients being treated. Again, in the Lancet study, it's in China. There are certainly differences in how people respond to this virus, both within a population like New Yorkers, and so we may assume as well across populations. The population treated in China is genetically very different than the population treated in New York City for the most part, and so you can imagine there are differences in rates of response to the drug, or some other difference in the population as well. Less diabetes, less hypertension, take your pick. Again, until we have that sort of table 1 published from the NIH data, we don't know. Or 3, there is some bias in one trial or the other, either in data collection or in selection, or the various biases of research. And that's why I really wish we had the full peer-reviewed manuscript of the NIH data available, and I don't know when it will come out. I suspect quickly, because it will certainly be expedited in every possible way. But occasionally we'll get top-line data and then the trial won't come out for months. This happened with the ischemia trial recently. I think there was certainly about a month delay. It happens. So, listen, the NIH trial, as they reported, is great. It's placebo-controlled. It is in sick patients. It has outcomes that matter, that are statistically different. So it probably works. It has good in vitro data. There's no reason to think that it doesn't. But before we go spending a ton of money on what is sure to be an expensive drug, because why would it not be? They'll get paid for it. Whatever price Gilead sets, someone will buy it. Before we go start spending a small fortune on this drug, I would like to understand why a negative placebo-controlled randomized trial happened the day before, or in fact the day of, the NIH data being published. There may be a very good reason. I suspect there is. I suspect it'll be pretty obvious once we get all of the cards on the table. But if it's not, bears looking at, certainly. Anyway, thanks for nerding out with me. That was fun. I like talking about evidence-based medicine, and I just have a feeling that someone's going to call me on something silly that I said. I don't know what. I think I was pretty careful about talking about this and the various possibilities, but we'll find out together. In the meantime, it's late. And thank you for listening to me rant about Remdesevir. For my part, I'm happy to get back to my regularly scheduled programming, take care of my patients who need me. I keep getting all these requests for home health aid evaluation forms that I've been putting off for 2 months while COVID swept through the city. And so I'm very excited to sign and rubber stamp a couple of home health aid forms. Not really excited for that part, but I am excited to get back to taking care of people who need me in whatever those needs should be. And if I don't see COVID again for a little while, I won't really complain. Let's hope we're that lucky. Have a good night.